Good day, learners. I welcome you to the last study session of this course, PHA 302, Pharmacodynamics and Chemotherapy. Today, our interest in study section 9, which is the last study section for this course. I believe that with the previous studies or study sections, we have been able to learn one or two things. Today, our interest will be on endocrine pharmacology. Endocrine pharmacology, and specifically thyroid agents. And I want to believe that we all understand what we mean by endocrine. Endocrine. Endocrine are majorly the ductlets talking about hormones being secreted by glands in our body. And you have many of them in the body. But majorly our focus will be on thyroid agents. And I want to believe that we're all familiar with the different types of thyroid hormone that we have and their physiological effect in the body. And when there is low secretion of this hormone, you all agree with me that it will bring about certain disorders in our body. And when you have overproduction of this hormone, it will equally bring about many disorders that are not. So today we'll be looking at some of these. So we'll be dealing with endocrine pharmacology, thyroid agents in mind. So our learning outcome for this study section will be that as learners, you should be able to describe an overview of the endocrine gland and the control of synthesis of hormone. Discuss thyroid glands, hormones, discuss under secretion of thyroid hormone disorder and their management. And lastly, we'll be looking at drugs used in over secretion of thyroid hormones and their examples. Okay, that's the second to last. And the last aspect is we'll be briefly looking at thyroid crisis. Thyroid crisis. Now, by way of introduction, the metabolic effect of the different systems of the body is controlled by autonomic nervous system and the secretion of the endocrine and ductal. So this statement is reminding us of our knowledge of physiology. That most of the metabolic processes that goes on in our body, they are being controlled, one, by autonomic nervous system, two, by the secretion of endocrine, ductal gland. So these secretions are a heterogeneous group of chemicals known as hormones, which are released into the bloodstream and travel to all parts of the body. Hormones exert their actions either on specific organs or specific metabolic process. Yeah, from that statement, you discover that each of the hormones being secreted in the body, they have their receptors and they act specifically in specific parts of the body to exert their actions. So, especially on specific organ or specific to bring about specific metabolic processes. And in contrast to the actions of the autonomic nervous system, they produce relatively low compensation for changes in the internal environment. In this study session, you will be introduced to control and function of the thyroid gland, disorder of the thyroid gland, and the pharmacological effect. Now, we want to have an overview of the endocrine glands. So the secretory activities, I will run through this because I know with our knowledge of previous knowledge of anatomy and physiology, even with biochemistry, we understand better what we're saying. That will serve as a foundation to the what we're about to learn today about the pharmacology of the endocrine. So the secretory activity of the endocrine gland is controlled by the central autonomic nervous system together with the secretion of other endocrine gland by feedback from the metabolic effects the hormones produce and by central and dominant nervous system. That is, it's not under the control of will. I want to believe you understand that. Pharmacology of the individual hormones is of importance as the knowledge of their function is vital to the understanding of normal control of metabolism, and also because under or over production of the hormones have striking metabolic consequences. I've been able to explain that. So in an effort to find substances which can replace natural hormones in state of underproduction, many compounds have been synthesized which can mimic, antagonize, or interfere with the production of natural hormones. Still on overview of the endocrine glands. In clinical practice, hormones and hormone-like drugs are mainly used for one, replacement therapy. You should take note of that. Most of the time in practice, in clinical practice, we use hormones or hormonal drugs to bring about or are being used mainly for these three different purposes. That is, one, replacement therapy, e.g., insulin in diabetes mellitus. You all understand insulin, especially insulin dependent diabetes. So it's a replacement therapy. Then, two, testing the functional integration of an endocrine system. For diagnostic purposes, you can use what? Hormones. And three, treatment of non-endocrine diseases, e.g., steroid in rheumatic arthritis. So rheumatoid arthritis, you can use hormones, corticosteroid. So non-endocrine disease. So the ability of a cells to respond to a particular hormone depends on its possessing specific receptors. Take note of that. Hormones or endocrine secretion doesn't act without having a specific receptor. Each of the hormones that you can mention, they have their specific receptors. So the ability of the cells to respond to a particular hormone depends on it possessing specific receptors with which the hormones interact. So without the receptors, the hormone will not have any effect. So control of synthesis and release of hormones. Several of the endocrine glands, that is thyroid, adrenal cortex, ovary, and testes, under the control of the anterior lobes of the pituitary gland, which is an endocrine gland. So the chain of events leading to increased output of hormones from these glands involves stimulation of the release of the appropriate trophic hormone from the pituitary. Release of trophic hormones is under the control of neurons of the hypothalamus. Mainly at this level, integration of nervous and endocrine system take place. So thyroid gland hormones and anti-thyroid drugs. The thyroid gland synthesis stores and secretes the iodinated amino acid hormone, L-thyroxine and L-thyroiodothyronine. This liothyronine. The thyroid hormones regulate oxygen consumption, heat production, and a wide range of metabolic processes that are essential for normal growth and development. So if you remember your physiology of thyroid gland, you discover that thyroid gland functions as regulations of oxygen consumption, heat production, then a wide range of metabolic processes that take place in our body. And lastly, they are essential for normal growth and development in our body, of various systems in our body. So the thyroid gland of man also synthesizes calcitonin, and we all know the function of calcitonin. Now, we want to talk about what? Control of the thyroid gland. Control of the thyroid gland. In normal subject, the secretion of the thyroid hormones, T4 and T3, is regulated by the hypothalamus and pituitary gland. Hypothalamus produces the thyrotropin releasing hormone, TRH, which stimulates the pituitary gland to synthesize and release the thyroid stimulating hormone, TSH. The latter regulates the thyroid gland's ability to extract uh, to extract iodine or iodide from the blood for building up the thyroid hormone. So for the building up or for the synthesis of thyroid hormones, there should be production, or we need what? Iodine in the body. So iodine must be added to our food, or if there's any deficiency in iodine, the iodine should be added to our food too, because it's good synthesis of what? Thyroid hormone. So effect of thyroid stimulating hormone on the thyroid gland. Number one, it promotes the uptake of iodine by the thyroid cells. Two, promote the synthesis of thyroglobulin. Three, promote the release of T4 and T3. And four, it increases the thyroid gland size and the vascularity. Now, disorders of the thyroid gland function. The disorder of the thyroid gland function. Thyroid gland will be subjected to certain disorders in function. This could be in the form of undersecretion, that is hypothyroidism. In infants, leads to cretinism. In adults, this undersecretion, that is hypothyroidism, leads to maxilloedema and Hashimoto diseases. Then the oversecretion, which is also known as what, or otherwise known as what, hyperthyroidism. So, and this now, okay, we want to look at undersecretion of thyroid gland hormone, that is hypothyroidism. So undersecretion of the thyroid gland leads to cretinism in infancy, maxilloedema, Hashimoto's disease in adults. In such cases, replacement therapy, that is thyroid preparation, indicated. So we want to look at thyroid hormone, which are T4 and T3. So, and looking at the pharmacodynamics of these thyroid hormones, free form of thyroid hormone T4 and T3 dissociate from thyroid binding protein and then enter the cell by diffusion or by active air transport. Within the cell, T4 is converted to T3, which enters the nucleus. There, the T3 binds to the specific T3 receptors, protein causing DNA-directed and mRNA and protein synthesis, thus mediating a response. These explain the time lag of hours or days for the hormone to give maximum effect. Now, the actions of the thyroid hormone. So, one, stimulation of the metabolism in general, causing an increase in oxygen consumption and in metabolic rate. Two, influence growth and development. Looking at the pharmacokinetics, inactivation of the thyroid hormones eventually occur by deiodination, deamination, decarboxylation, conjugations, and excreted as glucuronide and sulfate. So these occur mainly in the uh, liver, and the free and conjugated form are being excreted in the bile. Now, thyroid preparations. So we are still talking about hypothyroidism. So some of the thyroid preparation that can be used are L-thyroxine, that is etroxine in tablet form of 0.05 to 1.0 milligram each. A single dose reaches its maximal effect in about 10 days and passes off in 2 to 3 weeks. Two, L-thyroxine sodium, that is centroid sodium, is the synthetic sodium salt of levothyroxine. This preparation is given by intravenous injection in case of emergency, that is, in case of a maxilloedema coma. Three, low-thyronine sodium cytomel is the synthetic sodium salt of levotriiodothyronine. It may be given intravenously in emergency cases of maxilloedema coma. It is more potent than levothyroxine 4 times as potent. It has a quicker onset of action at duration. T3 has the advantage over T4 in that it is more readily absorbed by the GIT. 4. We have leo, Leotrix, that is euthyroid. Euthyroid is a preparation in tablet form containing a mixture of levothyroxine and leothyronine in the ratio of 4 to 1. Now, the therapeutic uses of all these drugs is for replacement purposes or replacement therapy in hypothyroidism, cretinism, and maxi edema coma. So, hypothyroidism, we want to look at the treatment, replacement therapy by L-thyroxine. Initial dose is 50 to 100 milligram per day. In old patients with heart disease or hypertension, this should be achieved gradually, starting with 25 gram per day for the first 2 weeks, then increasing the dose by 25 to 50 gram every fortnight until symptoms are relieved, usually at 100 to 200 gram per day. The maximum effect of a dose is not reached for about 10 days and passes off over about 2 to 3 weeks. Now, creatinine or cretinisms, it is due to thyroid deficiency during development caused by congenital absence or incomplete development of the thyroid and is characterized by gross retardation of growth and mental deficiency. Success in treatment of cretinism depends on the age at which therapy is started. If therapy is initiated within the first few weeks of life, normal physical and mental activity is always achieved. The most critical needs of the thyroid hormone is during the period of melanization of the central nervous system that occurs all the time of birth. Treatment of cretinism, L-tyrosine, dose 10 to 15 gram per kilogram as an initial dose. Individual L-thyroxine doses are adjusted at 4 to 6 weeks interval during the first 6 months, at 2 month interval during the 6 to 18 month period, and at 3 to 6 month interval thereafter to maintain serum thyroxine concentration in the 10, 10 per, I mean, 10, 10 gram per deciliter range, and serum TSH value below 20 microgram per liter or millimole per liter. Sorry. Now, take note. I want you to take note of adjusted doses. It's very, very important, especially it may come in the your MCQ talking about the thyroxine in the treatment of cretinism. So take note of that. The assessment that are important guide for appropriate hormone replacement include physical growth, motor, motor development, bone maturation, and developmental progress. So you may be asked that what are the uh, assessments that are important that can serve as guide for appropriate hormone replacement therapy. So number one, we talked about what physical growth. Two, motor development. Three, bone maturation. And four, developmental progress. So I want to look at maxilloedema as one of the hypothyroidism disease condition. So maxilloedema coma. This is a medical emergency that occurs most often in elderly patients. Common precipitating factors include pulmonary infections, cerebrovascular accident, and congestive failure. The patient should be treated in the intensive care unit. An untreated patient dies from hypothyroidism, and two vigorously treated patient dies from cardiovascular collapse due to a precipitated rise in metabolism. Single dose of T4, 500 gram, intravenous of 50 gram of T3 is administered. So intravenous is life-saving. Hydrocortisone might be needed as prolonged hypothyroidism is usually associated with adrenal or pituitary insufficiency. Adverse effects of thyroid preparation. Symptoms and signs are those of the hyperthyroidism minus hypothalamus and goiter. Now, the major adverse effect of thyroid hormones or thyroid preparation for the hypothyroidism are the symptoms and signs that are those of what hyperthyroidism. That is, the hormones are in higher concentration in the bloodstream. So minus exophthalmos and goiter. We know what exophthalmos is. Exophthalmos is all about the demands of the supraorbital what do you call it, areas of the face, or goiter. And other signs are what? Tremors, insomnia, heat intolerance, arrhythmias, nervousness, weight loss, tachycardia, angina pain. So angina pain or heart failure are liable to be provoked by vigorous therapy. If they occur, thyroxine must be discontinued for at least 1 week. Now, I want to look at the oversecretion of the thyroid gland, which is otherwise known as hyperthyroidism. Hyperthyroidism. It is an increase in the release of thyroid hormones. Under these conditions, thyroid stimulating hormone level become very low and the pituitary becomes unresponsive to thymo, I mean, thyroid regulating hormone, thyroid releasing hormone, sorry, TRH. Excess thyroid hormone production will increase the metabolism together with overactivities of the sympathetic nervous system, giving rise to the clinical condition known as thyroid corticosis or Graves. So preparations used in hyperthyroidism are: one, iodide, e.g., potassium iodide and Lugol solution. Two, thyroid derivatives, that is, the trade name is thionamide, e.g., propyltyrosine, carbimazole, metamizole. Then three, we have perchlorate, e.g., potassium perchlorate. Then the fourth one is radioactive iodine, that is iodide 131, iodide 13, and iodide 132. Iodides. So the pharmacokinetics of iodide is the exact mechanism of action is not entirely clear. In hyperthyroidism, in hyperthyroid subjects, a moderate excess of iodine may enhance hormone production, providing fuel for hormone synthesis. Remember that for T4 and T3 to be synthesized, to be produced, so an individual need adequate uh, supply of what? Iodine. So iodine is being used to fuel the hormone what? Synthesis. So that is why iodide is being used. So by the time we have enough, it can. Uh, so in hyperthyroid subject, a moderate excess of iodine may enhance hormone production, providing fuel for hormone synthesis. High excess, however, has an effect on the thyroid gland, which is opposite to that of thyroid stimulating hormone, that is, increase iodine trapping. So we want to look at another drugs for hyperthyroidism, where thyroid derivatives, that is thionamide. The pharmacokinetics, the main action of thyroid derivative is to reduce the formation of thyroid hormone by inhibiting the thyroid peroxidase catalyzed reactions to block iodide organification, that is, inhibiting the incorporation of iodide into organic form. Iodotyrosine and by inhibiting the coupling of iodotyrosine to form T4 and T3. Thionamides are usually slow. Their onset of action range from 2 to 3 weeks. Note, with every dosage, the with every dosage, the reduction in hormone synthesis may be sufficient to induce the pituitary to produce more thyroid-stimulating hormone, which in turn uh, produce thyroid uh, thyroid hormones. Now, want to look at the pharmacokinetics of thyroid derivatives. Propylthyroxine is rapidly absorbed. A peak serum level is attained after 1 hour, mostly excreted by the kidney as inactive glucuronides within 24 hours. Half-life is 1.5 hours. Poorly crosses the placenta barrier. Peripherally, it inhibits the conversion of T4 into the more active T3. Metamizole, which is another example, is completely absorbed but variable rate. It is it is readily accumulated by the thyroid gland. By the thyroid gland, the excretion is slower than propylthyroxine. So I hope you are all following me. Now, we want to talk about carbamazole. Carbamazole is a prodrug and it's rapidly converted to the active form metamizole. Note, the half-life of these drugs has little influence on the duration of their antithyroid action or the dosing interval because both agents are accumulated in the thyroid gland. Thionamides are metabolized in the liver and excreted in the urine as sulfate ester and glucuronides. So, we want to look at the preparations. Propylthyroxine 50 milligram is the least active thionamide. Dose is 100 to 150 milligram per 8 hours or 8 weeks initially, then 50 to 150 milligram once as maintenance dose. Then carbamazole, neomacazole 5 milligram. This is a prodrug. Dose is a 30 milligram per day initial dose, then 5 to 15 milligram per day as maintenance dose. Then we talk about metimazole, that is tapazole 5 milligram. It is about 10 times as potent as propylthyroxine, and the dose is 30 milligram per day. That is 30 milligram per day as initial dose, then 5 to 15 milligram per day as a maintenance dose. So, we want to look at the adverse effect. We have popular skin rash, lymphadenopathy, leukopenia, agranulocytosis, aplastic anemia, but less frequent than perchlorate at 0.1%. Thyroid enlargement with increased vascularity. So some of these drugs are equally give rise to what enlargement with increased thyroid gland with increased vascularity. Note, blood count is essential during therapy, especially if the patient develops infection or anemia. So at interval, there should be blood count for this hormone. Then contraindication. Pregnancy. It is contraindicated in pregnancy. These are contraindicated in pregnancy. So we should take note of that. These are contraindicated in what? In pregnancy. So, sorry, just a minute. Just a minute. We are almost done. We are almost done. So, now, the propy, okay, pregnancy It can be considered in pregnancy since thyroids cross the placenta barrier causing fetal gutter. Pre-thyroxine has the least effect in this case. Lactation, since it can be transmitted into uh, the breast milk. So therapeutic uses. Preparation of patient for surgery until the patient's thyroid hormone level fairly decreases before giving iodine. Chronic treatment of hyperthyroidism until spontaneous remission occurs. Then management of thyrotoxic crisis, thyroid storm, along with propranolol and other drugs. Potassium perchlorate. Potassium perchlorate, mechanism of action. So perchlorate acts by blocking the iodide concentrating ability of the thyroid gland and compete with iodide for uptake. Potassium perchlorate is quite effective, but the high incidence of the development of granulocytosis when given in high doses, that is 2 to 3 grams daily, leading to fatal aplastic anemia, render it obsolete for treatment. Uses to discharge inorganic iodide from the thyroid gland in a diagnostic test of uh, magnification. Now, radio iodine, that is iodine 131 and iodide 132. Then we look at the pharmacodynamics of these drugs. Mechanism of action. Both isotopes are treated by the body just like the ordinary non-radioactive iodide. So when swallowed, they are concentrated in the thyroid gland. They emit mainly beta radiation, 90%, uh, and some gamma radiation, which penetrates the thyroid cells only without damage to the surrounding structure, particularly the parathyroid. The destructive effect of radioiodine on thyroid tissue is caused by beta radiation. The gamma rays are useful for estimating the quantity of the radioactive materials in the gland and can be detected by replacing a Geiger counter in front of the neck. Then, talking about pharmacokinetics, it is rapidly absorbed after oral administration, rapidly absorbed and concentrated by the thyroid and incorporated into storage follicles. Half-life of uh, uh, isotope iodide 131 is equal to 8 days, and the half-life of the isotope iodide 132 is equal to 2 hours. So the cytotoxic effect on the gland is delayed for 1 to 2 months, reaches maximum effect after 3 to 4 months. Then the therapeutic effects in the treatment of some cases of hyperthyroidism, e.g., in patients above 40 years, in combination with surgery in some cases of thyroid carcinoma, diagnosis of thyroid gland function by measuring the 24 hours uh, uh, isotope of 132 up, and we have side effects, hypothyroidism. So, contraindication is contraindicated in pregnancy, since it crosses the placenta barrier, thus affecting fetal thyroid. Then it's contraindicated in children. Then the preparation and dosage. Isotope is available sodium radioiodine, generally given orally, but intravenous preparation are available. Dose. For diagnostic purposes, isotope of iodine 131 and 132 is usually preferred owing to its short half-life of 2 hours. Isotope of iodide 131 is usually used for treatment. Dose is calculated according to the size and approximate weight of the gland. Drugs that control the peripheral effect of hyperthyroidism. Drugs that control the peripheral effect of hyperthyroidism. There is evidence that there is increased tissue sensitivity to catecholamines in the hypothyroidism, and that This is a cause of some unpleasant symptoms, especially in relation to the heart, palpitation, cardiac, etc. Quick relief can be obtained with beta adrenaline receptor blocking drugs, e.g., propranolol, 20 to 40 milligram orally every 6 hours. Inhibits sympathetic activities and decreases peripheral conversion of T4. Then diltiazem 90 to 120 milligram 3 or 4 times daily could be used in patients with whom beta blockers are contraindicated. Note, beta adrenaline receptor blockers are especially useful during the long wait for the effect of radioiodine thionamide treatments. So we are almost coming to the end of the lecture. So we want to look at thyroid crisis, which is the last subtopic. Thyroid crisis, otherwise known as thyroid storm. This is a life-threatening syndrome caused by the liberation of large amount of hormones in the circulation. Treatment is urgently required to save life. It includes propranolol should be given immediately, 1 milligram per minute by slow intravenous injection to a maximum dose of 5 milligram in severe cases. If propranolol is contraindicated, 5 to 10 milligram per hour of IV infusion of diathiazem is given instead. Then potassium iodide, 1 to 2 grams per day to reduce the release of the hormones. Then antithyroid drugs like thiorine may sometimes be added. So mental disturbance may be treated with chlorpromazine, that is Lagatil. Then hyperpyrexia is treated by cooling or aspirin. Then hydrocortisone 50 milligram intravenous per 6 hours. This will protect the patient against shock and will block the conversion of T4 to T3 quickly, decreasing the level of thyroactive material in the blood. Drug effect and thyroid function. Still under thyroid crisis. Drug-induced hypothyroidism side effect. Several drugs may depress thyroid function by interfering with synthesis, secretion, and transport of thyroid hormone, NZ, that is non-steroidal anti-inflammatory drugs. Then glucocorticoids, X-ray contrast agent, alpha and beta adrenaline receptors antagonists, sulfonylureas, tranquilizers, and lithium. Then we look at drugs hindering the absorption of oral T4, and these are cholestyramine, cholestyramine, aluminum hydroxide, sucralfate, ferrous sulfate, and some calcium preparation. This one can hinder the absorption of oral T4. Then drugs which alert T4, which alter T4 and T3 metabolism. This hepatic enzyme inducers. Hepatic enzymes inducers can do what? Can alter the metabolisms. So, and these are very, very important. Take note of. So, sorry. So, drugs which alter T4 and T3 metabolism are hepatic enzyme inducers like phenytoin, carbamazepine, phenobarbital, and rifampicin. These are the things. These are the drugs that alter the metabolism of these very particular drugs. So, in summary, I want to believe that we've been able to learn one of the things that hormones exert their actions either on specific organs or on specific metabolic processes. So the secretion and the secretory activities of the endocrine gland is controlled by the central and autonomic nervous system together with the secretion of other endocrine glands and by feedback from the metabolic effect of hormones produced. Now, another thing is that Several of the endocrine glands, that is thyroid, adrenal cortex, ovary, and testes, under the control of the anterior lobes of the pituitary gland, which is an endocrine gland. The release of trophic hormone is under the control of neurons of the hypothalamus, and it is mainly at this level that integration of the nervous and endocrine systems take place. Thyroid hormones regulate oxygen consumption and heat production and a wide range of metabolic processes and are essential for normal growth and development. So another thing is that under secretion of the thyroid gland leads to cretinism in infancy and macular edema or carcinomatous disease in adults. And the excess thyroid hormone production will increase the metabolism together with overactivities of the sympathetic nervous system, giving rise to the clinical condition known as thyroid toxicosis or Graves' diseases. Talking about the preparation used in hypothyroidism, we made mention of iodide, thyroid derivatives. Then we talk about perchlorate, then radioactive iodine. Then last we talked about what? Thyroid crisis, that is thyroid storms. About thyroid crisis or thyroid storm. So, and we're able to uh, see that thyroid crisis is a life-threatening syndrome caused by the liberation of large amount of hormones in the circulation. Last thing there is that we talked about treatment is urgent. It's urgently required to save life when an individual comes down with what? Thyroid toxicosis or thyroid crisis. So we have come to the end of today's lecture, and I want to use this time to wish you safe trip for your face-to-face facilitation and your exams. To use this as a reminder or use this time to remind you, read in between the line and understand everything about all this lecture because your question, your exam is going to be MCQ. And you know what that it means? MCQ come in form of filling the gap, multiple choice questions or single answer choice questions. And so that's why you need to read in between the line. So I wish you success. Thank you. God